Welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery 5.21.1 upgrade webinar. Today is Wednesday, February 24th. Thank you everyone for joining. Again, just our agenda, welcome and introductions, and then I'll turn things over to Carol for a call overview and walk through the DCF, and then we'll finish up with any of your questions from today's presentation. Again, please be sure to submit your questions via the Q&A. That is very helpful for us, especially while we're walking through this form, so we can have a record of these questions and address any issues in the training manual accordingly. So again, please be sure to submit your questions via the Q&A. Let's see here. I don't know, Carol, do we have the raise hand function enabled for this call today? I'm not sure.
We can, but it's better if folks go through the Q&A so we can have a list of those. Perfect. But I'll put that, do the raise hand function as well. Sure.
Thanks. Sorry, but yes, again, please, everyone, please do submit your question to the Q&A so we can have that that copy of that question and can track accordingly. On the call today from STS, we have myself and Carol Crone, and then from the IQVIA team, we have Rhonda and Melanie joining us as well in case we have any questions for the IQVIA side. And also we will have Dr. Wormuth will be joining us here shortly to address questions as well. I just wanted to point out before we get started that there is a draft. The draft data collection form is posted out on the STS website. This was posted prior to our previous call. FYI, I will be posting an updated version, or marketing will be posting an updated version. Hopefully they can have it posted by this Friday. We'll be updating just some minor labels, corrections, some spellings, just some minor updates that will be updated on this new version. So once that is posted, there'll actually be the date will be posted as well, updated as well. So hopefully, again, we'll have that posted by Friday. With that, I think I'm going to go ahead and turn things over to Carol for her portion of the presentation. So Carol, turning it over to you.
Yep, thank you. Thanks, Leanne. And Dr. Wormuth will be on here shortly to help. So we had I hope everybody's having a good day. We are going to start with a couple clarifying points that came up on the last webinar walkthrough for the DCF, and one of those was related to the ECOG field being required for all cases, since we're getting away from the analyzed, non-analyzed case form. We verified with the surgeons, and it was great that the core group members had brought this up. There will be, it will be required on the analyzed cases, but it will not be required on the non-analyzed cases. It will still show up on the MVR as missing for all cases, but you can filter it out using the filters that are available in the missing variable report. And I'm assuming you're doing that anyway. If you're submitting all your cases, you're only really concerned about the missing variables on the analyzed side. So you can still do that. All other cases will, all other required blue underlined fields will be required on all cases. They will flag, I think we set those errors to either critical or the error level of severity. Melanie, do you remember how we set those? You might have to verify on the next call. Or Leanne.
Yeah, I think we set those to critical for those required fields.
Okay, so all, thank you. So all blue underlined fields will be set to critical. The level of critical if they're missing, which means your record won't be able to get in. The only field that will not be set to critical, which is a blue underlined field, will be this ECOG field. It will still show up, I think, as a warning, but you can ignore it for the non-analyzed cases if you didn't provide it. Next slide. So I can see Mindy. So you will an ECOG be required for hernias? It will if you're not going to provide it, it's not going to stop your record from getting in, no matter what type of case it is. So you should still review your missing variable report. Make sure you're providing ECOG scores. It will be required on lung and esophaguses. Hernias, I don't believe will be requiring it, but the critical level will not be set for that, regardless of what type of case it is. So you just need to check your missing variable report. The next And I'm not sure why that highlight showed up that way, but the next part I want to talk about, and I'll show you more on the DCF when we get there. This is just to give you a written description of what this will look like. This is the procedure weighting. We were asked to have to add some type of check. Again, this suggestion came from Katie from the core group, and this was a great suggestion. We were able to work with IQVIA to put this in place for version 5.21. This is procedure weighting. And what will happen is that if you code a primary procedure, if you code multiple procedures and you code your primary as a procedure that has a lesser weight, it will flag an error and you will be notified. I think we set these to errors. Some type of flag will fire. You'll be notified that the primary procedure is coded incorrectly and you need to go back and fix it. So it's kind of, as Dr. Wormuth had put it, it's kind of like playing football. The highest score wins, ties are ignored, and it should be the primary procedure, which will be the score with the highest. So each procedure listed in the section will get the section weight. The task force consensus was that the biggest procedure performed is an esophagectomy. So you'll see the esophagectomies, the esophagus section will have a weight of 70, lung cancer section will have a weight of 60. So I'm going to go over to, I'll show you what that looks like. And we'll add this on. We just finalized everything with IQVIA, so we'll add it on to the DCF. First is the ECOG score. I just want to talk about that, which we did. And then now we're going to start down in the operative section. And I just want to make sure, does everybody able to pull up the data collection form? And if not, if you want to raise your hand, let me know that you're not quite there yet, and we'll give you a few seconds to get caught up with pulling the form up. And I can show you where that's at. So we all start at the same spot. If you go to, so it looks like a couple people aren't able to find it. So if you go to the STS homepage, the registries, STS National Database, General Thoracic tab, Access Data Collection Resources, and then it's the version 5.21.1, and you'll find it here, and it'll pull up in a Word document. So hopefully, does it look like everybody's good? I think so. Okay. So for the operative section, we've already went through this section. We got down to the analyzed procedures, and this is where we had stopped last time. The form on the right, I just added in the weight. You'll see on the left-hand side of the screen, or on the left-hand side of the document on the right, you'll see that these values I added in here. So we analyze case for the lung procedures are weighted as a 60. The esophagus procedures are weighted as a 70. So say that you do an esophagectomy and you end up doing one of the procedures up here that's weighted as a 60. You should be coding the esophagectomy procedure as your primary procedure. So the procedure that has the highest weight is what should be scored as the primary procedure. And that's going to help with accurate coding of cases and for analysis. Previously, we did not have this, so whatever you put in as the primary is what was getting analyzed. So this will help ensure that we're analyzing the correct procedure.
Hi, Carol. The mischief maker's here.
Wonderful, Dr. Wormuth. Did you want to talk about your football analogy here?
Only if there's questions. I would hope it's pretty self-explanatory.
Yeah, I think so. There's one question. Will the various procedures also be weighted inside the individual categories? So I can answer that. I know the answer is no, except
Correct.
you see it broken out here under the lung cancer resection, where we have these concomitant procedures, which also says that you need to list in addition to a primary procedure code. So the primary procedure code would have the heavier weight. Oh, I didn't finish reading that question.
Oh, sorry, Carol.
That's okay. It went away so fast. So if more than one AP procedure done with esophagectomies or lung resections, will the program? Okay, so I think we've got that. All right, very good. So that's the major change here that will help ensure that we're coding the primary procedure correctly. And then you'll see as we go through this section, the form on the left are things that have been removed. We did a little bit of condensing to make sure we aren't double capturing things. Double
Carolyn,
X. Yes,
I think the plan is when we implement this check, it's going to apply to the 2.41. So they may see that, they may see a warning that the procedure, if they accidentally coded one of the minor procedures as primary, they might get that same warning.
oh, okay,
I'm sure we'll tell them when we turn it on.
yes,
Yep.
yes, here.
Yep, but we're starting off with just 5.21 at the moment, once that rolls. Yep. But
We'll start
eventually
with the new
those
version and
becomes-
then we can move it over, we can extend it into the previous version.
Right.
Okay. That might cause some, we'll have to talk about that and make sure we do it correctly, so we don't cause a lot of heartache at the site. By heartache, I mean double work or confusion. So then we get into the esophagus. We just, added some clarifying language here, added in some CPT codes. Nothing too major. And then you'll see that the minor or non-analyzed procedures, concomitant procedures, other than those lung concomitant procedures, are given a weight of 10. So for example, here, if you coded a hiatal hernia procedure and you coded a some type of thoracoscopy with an excision of mediastinal tumor, the mediastinal mass or mediastinal tumor thymus procedure, this would get a higher weight. So you would code this as the primary procedure over the hiatal hernia fundoplasty procedure or whatever other procedure you would have coded up there. And then the non-analyzed concomitant procedures, these are all those other type of procedures that we don't really need in the database, but some sites like to abstract everything. So we allow you, you're free to put those in. They're going to have the lower weight of a 10. And let's see here. We just did a little bit of cleanup, added a couple codes in. One thing I do want to point out that I think is going to be more common as we go through this. On the right-hand side, you'll see under, when we get down here to miscellaneous, you'll see this robotic assisted surgery. This is to be coded in addition to the other. So if you do a VATS, you would code this, a robotic assisted VATS, you would code this in addition to the thoracoscopy. There is no CPT code that is specific to a specific robotic surgery. So all of these procedures don't have additional codes that would include a robotic. You have to code the robotic assisted surgery separate, which is this S2900 code. So you would code your primary procedure, and if there was a robot assist, you would capture it down here. That was added in after some requests that we've received from the data manager community. The next thing that was added in is this procedure laterality. Primarily, we're looking at lung cancer procedure laterality, but there could be other lateralities that you would want to specify. If it's not applicable, you could just check not applicable. Otherwise, you could select which side it was on, left, right, left, or bilateral. And then we get into these. Yes, sir.
The one other thing I would point out is we made the sort of the gastric and feeding tube section in the minor procedures. So they might, if they're looking for some kind of feeding tube procedure, I think there was a gastric section.
I think we removed that, Dr. Warmuth.
Yeah, we did.
Dr. Fernandez, and we can talk about that
Okay, never mind.
later. Okay, it was there, but it was there at one point, but it got removed. I think we said we would capture those under other, and if they wanted to specify, they could. And then I think we also collect some of that, maybe in more specific within some of the sections. Okay, so procedure laterality, and then we have the 5 questions here that will open up the more detailed sections below. Again, you will only code primary lung cancer resection performed if there was a primary lung cancer, which means that the primary tumor was a lung tumor, not for metastasis. Same thing for esophageal. It has to be a primary esophageal cancer case. to go just to these. These two are your analyzed risk adjusted case types. Then the other, thymus, tracheal resections, and hiatal hernias. And then we get into the lung cancer. We made quite a bit of change down here, tried to clean it up some, got rid of some of these questions. This question here on the left where it says, was there a pathological diagnosis of lung cancer? We got rid of that. And we just made this radiographic. So what we want to know is clinical staging done, yes or no. If it was done, then select all that apply the way that it was determined. And if it was invasive mediastinal staging performed, we added in a couple new choices, and then you can select all that apply here as well. Tumor size, T-stage, nodes, and then metastases. And then the final pathological, which is to be completed if a lung resection was performed. And then the question is, was a lung cancer tumor was a lung cancer tumor present? Before it just said lung cancer, but what we want to know was lung cancer tumor present, yes or no? And then if the tumor was present, you'll provide the pathological tumor staging. Question regarding the invasion of adjacent structures. Was it reaching into any of these other structures? And then we did a change here in the nodal section. This was one of the areas we had a hard time auditing in the past. Dr. Wormuth worked really, but did some really great thinking on this to come up with the way that we could collect it. And Dr. Wormuth, do you want to talk about this through this section here?
Finding the unmute button.
Oh, good. Okay, good.
So yeah, the reason that this section is going to annoy you for 3 years is this information is really critical for building into the next staging system. And so we're the only database that actually tries to collect the specific nodal information in terms of what nodes were involved. So by completing this information, we are going to be able to really heavily contribute into the next staging system for, if you have a lower lobe, what nodes should you really be collecting at the time of operation? This is the information we're trying to collect and provide to the staging system. So, and we wrestled really hard with trying to leave like a default, if you don't answer, it doesn't matter. But after going round and round with the statisticians at DCRI, we feel we really needed to ask you to say this station wasn't sampled, or the node was malignant, or the node was benign. And again, it's just such critical information for those cases that we can get it for. And then we'll pick up right or left from your answer of the laterality. And so you'll notice that we didn't double the number of node stations because there's a left and right for everything but 7. And for that reason, we couldn't tell from these answers if you had a contralateral node, except for giving you the opportunity to say, yes, I sampled the contralateral node and it was malignant or benign, and that would actually make it an N3 node, which is why N3 is in parentheses. And then we want the total number of malignant nodes and the total number of nodes in the specimen, which usually is reported out on your path report now. And then we left this lung cancer nodes N0, N1, N2, N3, and NX because the core data managers that we work with asked us to leave it. So it's there, but you'll notice it's redundant.
Right. Do you want to talk thank you, Dr. Wormuth. Do you want to talk any about if a partial node is biopsied, does that still count as a complete node?
Yep, as long as, so that's one thing we have a real hard time telling is you could take one node, make 4 fragments, and pathology will say, well, there were 4 nodes. We can't get around that problem, so we just have to live with the number. And it really is just, if anything in that station is positive, it's positive, it's malignant or benign, if there's no cancer found.
Okay. Now, if that does happen and they take, 4 samples from nodal station 3, from nodal station 3 here, and they take
Yep.
4 separate samples, and they come back, the pathology says that there were 4 nodes sampled, but they were all from station 3. How should the data manager interpret that? Should they just
Well,
interpret
they
it
would-
as 1 node?
On this field that your arrow's on, they would tell us it was either malignant or benign, because we know it was sampled because there was a sample from there. And then they would count 4 if that's what's on the path report. Because when they get audited, they're going to look at the path report and say, well, your path says, 4 nodes. So that's the number that we're going to use.
Okay, we'll add that into the training manual then to help with that. Thank you. That's really helpful. Okay. We're just going to keep going a little bit further. Maybe we can get through this section and then we can go to questions. Right now we're at the lung cancer metastases, and it's asking you, we split M1 up into M1A, M1B, and M1C. Lung cancer histology, no major changes there, I don't think. Oh, I scrolled too fast. There we go. No major changes there. No changes in the grade. The lung cancer resection margins positive or negative. We removed these or moved them up, kind of changed that a little bit. That was that node section that Dr. Warmuth just went over for 1990 and 2000 in the previous version. Then we have the lung cancer resection margins positive pathology, and no major changes there. And then we get down to the esophagus section. I'm going to stop there and just take the questions that we have so far, just to make sure we don't confuse these with the esophagus section. Okay, next one is there any, first question is there any way that STS schedule a webinar to send email invitations to all data managers so we don't miss that? We do send notification out, but we don't send you email invitations. You can put it on your calendar when we send out those notices. I guess we could look at making registration required with if we sent out those notifications, we can make registration required, but that gets pretty complicated on the data manager end, but I'm happy to try to do that. That would allow you to download the invitation to your calendars. So let me know if that's something we could try that for one of these webinars and see how that goes. If you don't register ahead of time, I think you can still get in. You just have to register when you go to sign in. When can GTS cases start getting entered in the IQVIA online portal via their data form? So I think you're asking about direct data entry for IQVIA, and we have that currently available. Leanne, did you want to put the STSDB email in? And if anybody has questions on the direct data entry, they could reach out to Jane at that email address.
Sure thing.
Thank you. Now this version that we're going over now, version 5.21.1, this will go live with July 1st cases. So all cases, OR dates through June 30th will need to be entered in the 2.41? And
Yes.
all cases starting with July 1st, OR dates and after will be entered in this new form, which your vendors are currently programming and getting certified on. Next question. I might have missed the last webinar, but have we decided on abstracting all cases or just cancer cases? You can abstract all cases. The analyzed cases, the top 5 that we showed you will be the ones that go over to analysis that you'll get data back on, or outcomes back on. The code 38746. So Aaron's saying he doesn't see the code for 38746, and I pulled this up. This is the lymphadenectomy code, I believe, and I thought that we had, let me see if I can find it, and hopefully we didn't accidentally erase something here or have a wrong number. It's in here somewhere.
Yeah, I'm looking for it too, Carol.
Where did it
Gonna
go?
be up in the concomitant, I think.
Yep, I'm
bottom.
here. And when I searched it, it pulled up this section, so it's somewhere here.
Look up in the major section and the concomitant procedures.
Yeah, I don't think it's there. I don't see it.
No, we have, it's telling me it's here.
Oh, gotcha.
Look up in the 20s. Oh, yeah. It's right there, the second one on the left-hand column. And the concomitant procedures.
Which
Up in
one?
the 20 section.
In the 20s?
Yep.
Oh,
Mm-mm.
it's 32674. But that's the same thing. It must be include the thoracoscopy with, we'll have to double
There
check
you
that
go.
one, Aaron. It's telling me that 38746 is here somewhere.
Right. Lymphadenectomy. Yeah,
Did we have it in the previous version?
yeah. Yeah, it's in the previous, if you go
I
up,
think, was it labeled incorrectly?
it may have been one of those that we cleaned up. Because we had to correct some codes as well.
Yeah, some of the codes had certain numbers that were not correct on them. And we wanted the other number. So it was this thoracoscopy regional, including mediastinal and patricial nodes. We removed that. So it looks like we removed that.
Mm-hmm.
I have to double check on that, Aaron, and see what we did with that one.
Yep.
But it looks like we have what Dr. Wormuth is saying in the second one here on the right.
Three, 2, 6, 7, 4.
That's the code it looks like that we want coded. Would you agree, Dr. Wormuth?
Yeah, but remember the codes are just a guide. They're not,
Yeah.
it's the text that's the real go-to. So we tried to put the CPT codes because people know that, but the CPT codes can change and the text is still what we want.
Yeah, this is the code here that you should be this is the one here that you should be coding for that.
Mm-hmm.
Okay. We have to start with the procedure in blue first, then the procedures 32663. So you would code, I don't understand your question, Donna, I apologize. If you want to clarify, that would be fine. If two analyzed procedures are entered in the same category, where is the primary procedure identified in the database? So a tie is okay, and you would just choose whichever one you think is the primary out of those two procedures. Dr. Wormuth, do you have any other guidance that we can include in the training manual?
No, just pick the primary. We see some people that put
Okay, one more.
bronchoscopy as the primary
One more.
procedure. And we're trying to just pick that up and correct it.
Okay.
Carol, I need to leave. I'll follow up.
Okay. Next question, will there also be the assist by robotic technology? Yes, so we added that down here in the other, and you just code that in addition to whatever type of robotic surgery was performed. Does robotic assisted surgery need to be checked in the addition to the status of operation assisted by robotic technology? In addition to the status of operation? Is that a field, doctor? I don't know what that means.
I thought there was a separate field. I was just going to pull up the form and look for it.
Yeah, this is Katie. There is a separate field sequence for that we check. So
Okay.
I would assume we're going to keep doing that as well. It's right there.
So I'm not sure. Yeah. Thank you, Katie. Oh, so the assisted by robotic technology. Yes. So you can still check that here. We added it into the procedure codes. We added it into the procedure code so you can pull it up when you're looking at the procedures performed and run analysis at your site that way. And we could do better analysis as well for whichever procedure is with. So if we want to query data for all robotic cases from 2.41 and now 5.2, we'll have to look into different variable sequence numbers for our robotic cases. In 2.41, yes, and for 5.21, no. You can still check it here by assisted by robotic technology, or you can also look underneath the non-analyzed other section to pull up the combination code. Does lung cancer tumor size allow decimals? And that's a good question. I was going to pull it up to find this here.
Yes. We
This
made
is
sure we were able to
1800.
collect
Yeah.
fractional tumor sizes. So I think everything now is in centimeters and you can give us decimals.
Why can't I find my? So here are the data specs that were sent to the vendors, and you can go out, you can collect out to the decimal point. They're out, we set out to the thousands or out to the hundreds, but however far out your vendor goes is what we'll take in. If no cancer tumor present, I thought that these were not analyzed and therefore not be entered. So some sites, that's correct. You do not have to enter them if there was no cancer tumor present or the case was not performed for a primary tumor, but some sites do enter all of their cases. So this option is still available for those sites, even though they're non-analyzed. Where is the number of nodes? So total number of nodes assessed is here. Total number of malignant nodes is right above that. Are all cases mandatory starting July 2021? No, only the 5 procedures that we spoke about, which is the lung cancer. With these 5 are required. The other ones, if you want to enter them in, you can. They're not mandatory. Yeah, we'll have to look at 38746. I'm not sure why that was removed. I'll have to go back to the notes and check that out. If a surgeon performs a thoracoscopy via VATS, should I code the robotic? No, that I think it would have to say robotic assisted. Do you agree, Katie? If the
Yes.
surgeon performs a thoracoscopy via VATS, should I code? Okay. So you would have, it would have to be specifically stated that that was a robotically assisted VATS.
I mean, they're still gonna have to use the VATS code, the VATS lobectomy code, and then they would also mark the other new robotics code that you guys entered in.
Correct. Thank you. Starting July 1st, will we continue abstracting typical carcinoid tumors as mandatory cases? I think that would be if it is the primary tumor in the lung section or in the esophagus section, then you enter that case in. Yes.
That's a cancer.
Yeah. Okay. I'm not seeing any more questions. Let me see what's going on over here. Okay. Any more questions, or we can keep going? I think we still have another another 20 minutes, so we can go on to the esophagus section here. Sure, Erin, you can talk. I just need to unmute yourself, please.
Hi, Carol. This is Aaron. Are you able to hear me?
Yes, sir.
Hey, thank you. Can we just talk a little bit more about the new robotics variable? So in section E, there's a checkbox that says, was this assisted by robotics? And now we have to do, is it a duplication of now in the procedure? So we have to check it twice? Is that
It
my
seems to me
understanding?
some sites asked for that when we put out a request to get suggestions into what needed, and some sites requested that this be added here. So if you want to capture it here, you can certainly do that.
Okay, so just to be consistent, with the previous version and now the new version. So, there's in the operative section, section E, it says assisted by robotic technology. That was in the previous version. So we'll mark that as yes. And then we'll also have to check the S2900 code in the procedures. And again, if we want to
So
report
again,
on
as I said, sites asked for this to be added in. You can still capture it up in E as you were doing in previous versions, but sites asked for this to be added in down here using the CPT code, so they can combine this when they pull out all their procedures. This is what sites had asked. I'd be happy to go back and figure out why, but yeah, I would say you will capture it in both sections.
Okay, so then I totally understand, Carol, but then that's a duplication of efforts. And as we look at cleaning of the data and so forth.
You don't have to check it here, Aaron. If you don't want to check it.
But if some sites do, and if STS goes and wants to analyze that, I think we'd want to be consistent with all sites collecting the robotics, because it's going to be huge, as the robotics practice starts to evolve and move forward. It would be nice just to capture it in one place.
Yeah, absolutely understood. Thank you.
Thanks, Carol, for the opportunity.
Mm-hmm. Okay, check all of the procedures performs, indicate, circle the primary. How do we indicate the primary procedure if patient has 2 of the analyzed procedures?
You still enter, Nancy, you still enter the primary procedure on the primary procedure sequence number.
Thank you, Katie.
So that part doesn't change. The listing all procedures and then listing your primary procedure separately.
I do not see the field to do that. I think it's this. Are you talking about 1470 and 1480? They're here on the form. So are you asking, how do you determine which procedure is primary if the patient has 2 primary procedures? I think Dr. Warwick just addressed that one. Dr. Wormuth, are you there?
Yeah, I didn't see the numbers they were looking at, but essentially we're just trying to make sure that the primary procedure is kind of the biggest code, which the lung cancer resection, the esophageal resection, those are going to be what we would consider the primary part of the procedure. If it's a tie, we just take the tie. But again, we've had people put bronchoscopy and then lobectomy under other. So we're just trying to do a little data cleaning before you give it to us. Just warn you if we think there's a miss on the primary procedure. It won't reject your record. It's just going to flag it as, seems like this doesn't make sense.
Thank you. example of VATS lobectomy and VATS therapeutic wedge. So the therapeutic wedge is down here, and that has a concomitant that has this 20 here, and then a VATS lobectomy would be captured up here somewhere.
Actually, Carol, your therapeutic wedge is the weighed the same as the lobectomy. They're both 60. It's the diagnostic wedge down below that is weighted 20. The diagnostic wedge followed by anatomic resection. So your therapeutic wedge and your lobectomy are both in that top section.
Oh, sorry, here.
Yeah.
Right. And if you do a lobectomy and a therapeutic wedge, again, we would hope you'd put lobectomy as the primary procedure, but we're not going to ding you. And some people, the primary procedure really may be just a therapeutic wedge because they can't tolerate anything else. It's the diagnostic wedges we wanted to get out of there as the primary for these analysis cases.
Does the length of thank you, Katie and Dr. Wormuth. Does the length of the procedure help determine primary procedures? No. No, the answer to that is no. Will you please add the CPT code for resection of lung with chest wall resection? I don't think there was. I think when we went through, if I remember this one, the resection of lung with chest wall resection, we could not find a CPT code for that. So if you have one, happy to add it in there. But we could not find one. Please check sequence 60 section of analyzed cases. Oh, thank you. Got it. Yeah, couldn't find one, but if you have it, let me know. And I'll review the robotic one and see, we'll bring that to the task force and discuss that one. And then we'll talk about this one. I wanted to actually go through my notes because there's a reason why it's crossed off here to see what that was all about. Any other questions? Okay. And my suggestion is, we'll make changes to the data specs that they're already been sent to the vendor. So if there's a big issue, like a mapping issue or parent-child relationship issue, those are things that reasons why we would change the data specs. But something like double capturing, we will not change the data specs. My suggestion, and we'll educate folks on this in the training manual, if there isn't a big change coming through and we don't have to make a major change, we will not remove one of these options. This will be optional to code this code 7290 for sites that choose to code it, but it will be required that if it is a robotic case, that you will continue to code that other field wherever it went. In the operative status section here, you will still be required to code this if it was assisted by robotic technology, so we don't lose that data. Esophageal cancer section, I guess we can take about 10 minutes or so. We'll see if we can get through some of this and answer some questions. So we removed this wording here that said to be completed if esophageal cancer is suspected. We wanted on esophageal cancer if the patient was positive for that, not just suspected. So we worked on that weight question that was collected previously. I think it was up further on, it was collected on all the patients. And we just clarified, has the patient, we are most interested in this on esophageal cancer patients, so it was removed from that section and brought down here, and it's has the patient lost 10% of body weight in the last 3 months. We got a little bit more objective in this description of what we're looking for. The clinical staging done, we've changed these to select all that apply and just added in a couple clarifications there. And then esophageal tumor, we have T1 and then broke it out to T1A, T1B, and T1 unspecified. No major changes here for esophageal tumor, clinical diagnosis of nodal involvement or esophageal cancer metastases. And we made the tumor location a select all that apply. Planned stage procedure was also brought down here specifically for the esophageal cancer patients. And then Dr. Wormuth, we've added in this whole new section here, and this is where we're capturing the JTube placement for the esophagus patients. So we have the neck approach, and the neck approach is open, cervicoscopic, or robotic. And if any of these choices are selected other than none, then it would be a neck lymphadenectomy performed. And yes, with that neck dissection, or yes, without. The thorax approach, you can enter in the type of thorax approach, abdomen approach. And if they only use one, you can select none for what they did not use. Anastomotic method, esophageal conduit, pylorus management, and JTube placement, which could be pre-existing during surgery or post-surgery. Any questions on that section?
Hey, Carol, I want to motivate it a little bit more. So first of all, if you on the thorax tell us it's a thoraco-abdominal approach, we know that you were in the abdomen as well, so don't worry about an answer there. You can click none or open. Why don't we have open? Oh, laparotomy. You could click laparotomy as well. We'll drive it off of thoraco-abdominal. That's a technique from the left side that some places do and most places don't. So don't worry about that if you guys aren't doing it. And then you told us the procedure with a CPT code, but they are way out of whack in terms of how people are putting things together. And so, for instance, I use the robot in the belly and I do an thoracotomy for my esophagectomies. And so there's not a CPT code for that, but this will let us figure out just what your surgeons are doing. And then we don't really care whether you did an open pylorus management, or you did it with the robot. We just want to know what you did to it. Pyloroplasty, pyloromyotomy, I didn't do anything. I injected Botox. And the same thing with the JTube. We don't really care how they did the JTube, just what was the timing? Did it go in before, a couple months before, because they were getting adjuvant chemotherapy? Was it put in during surgery, or did you have to take them back and do a JTube because you tried to get by without it and you couldn't? So that's the reason why we've kind of broken this section apart, is to try and really figure out just what parts are being done in what fashion, and the CPT codes just don't give us that information.
Dr. Wormuth, does it matter who inserts the JTube?
No, nope. So if IR puts it in, or the GI team wants to do it at pre-existing, that's fine. Or even if it's done by another surgeon, 2 hours away, and the patient comes for definitive treatment, we just want to know, was a JTube involved in the care? And if it was, when was it first placed?
Wonderful. And what happens if they have one that's before and one that's after?
I would just put the pre-existing one, because we know they're going to carry through.
Okay. So I think the reason we would put the pre-existing one is just to get a good picture of what the patient looked like previous to surgery versus that's why you would code that instead of a post-surgery one if the patient had both, right?
Right.
You would know that was already there. Okay.
Yep. And then the other trick here is the hand assist question, and that's going to cause some aggravation. Essentially, we were trying to figure out, if you did it robotically or you did it laparoscopically, but then they made a little 2-inch incision so they could pull up the bowel and do it. That's what we mean by hand assist, where you're really just only able to stick your hand in through the incision, or a smaller incision than that.
Okay.
That's the madness behind that question, and the definition is very difficult. So just be consistent.
we'll work with you, Dr. Wormuth, when we get to that section in the training manual to make sure that it is, make sure that we're explaining that correctly for the data managers.
Oh, no, you won't. I don't want to own that one.
Yes, you will. If the JTube is placed during surgery, do we mark pre-existing and during? So he said you can only mark one here, and you would mark that as pre-existing.
Well, if you put it in during surgery, I would check the during surgery box. There are some people that come, already with a JTube.
Yeah, it says if it was, it says if the JTube is replaced during surgery.
Yeah, then use pre-existing.
Okay, thank you. If the JTube is placed post-surgery, is there a time frame?
Yeah, after they leave the recovery room from their esophagectomy procedure, that would be post-surgery.
And is there a time frame that it ends? Is it just within this hospital stay, or is it, I think we would want it just within the hospital stay, right?
Well, I would say 30 days.
30 days. Okay, so we'll make sure that's in the training manual as well. Okay. Leanne had a family emergency, so if everybody could keep her in your thoughts, that would be greatly appreciated. With her dad. Thank you. So the next section is the pathological staging of the esophagus. We changed it to esophageal cancer present, yes or no. So if you answer yes, then we want to know the tumor, nodes, metastases, histopathologic type, the CA histologic grade, number of lymph nodes sampled, and esophageal resection. No major changes within this section. When we get down to the esophageal cancer resection margins positive, then we did get a little bit more granular here, and we want to know, is it proximal or distal? So is it esophageal or is it gastric, where those margins were positive, or radial, which is down here, ended up on the next page for this one here. We have about 6 minutes left. I can keep going if you want. Dr. Wormuth and Katie, are you good with that?
Yep.
See if we can get through this. Okay, thanks, guys. Thymoma, thymectomy, mediastinal mass resection, myasthenias gravis. Cleaned up this a little bit. I'm not sure. We just changed the way we were collecting this, it looks like. So select all that apply. Again, the form on the left is a draft form. So it's it was what we used during the upgrade calls. Not all of the changes are demonstrated when we built this form on the right. We cleaned it up more, so you might see different formatting on the left than the form on the right, but the form on the right is what we're going with. So we just changed the way this is collected. So if it's symptomatic myasthenia, then you would select all that apply for chronic medical treatment, mistone steroids, or other immunosuppressive therapies.
And this section remains elective. Your program can choose to give us this data or not.
Oh, I see. So Dr. Wormuth, let me clarify something on this. You saying that. We have these 5 up here, these 5 primary type procedures with primary lung, esophageal. So sites are, what are we requiring? Sites are required to provide data for lung cancer and esophageal cancer primary tumors. There's no question on that. But when you say
when
that
we audit, those are the cases that we will be pulling from.
Okay.
At this point in time.
Now, if a site wants to enter in their thymus cases, or if they don't want to, if it is a primary thymus type of procedure, any of these procedures, tracheal or hiatal hernia, are we telling sites that these are optional?
Yes, they've always been optional. So we would be happy to collect the data if the site wants to give them to us. And ultimately, we will be analyzing that sooner rather than later. Okay. But we aren't auditing programs that say, hey, you did not tell us your thymus procedures. We are not doing that at this point.
Okay.
So we'll take the data if you want to give it to us, but you don't have to.
Okay, thank you. That's very clarifying for me. Thank you. Sorry for the scrolling. So the thymoma, thymectomy, Dr. Wormuth said these cases are optional. If you want to submit them, then you'll need to submit the complete data on them, except of course for the ECOG score. The preoperative management, no major changes there. We changed this from millimeters to centimeters, and just a little clarification. We added thoracotomy into the operative initial surgical approach. This is the initial approach, not if there was a conversion or another incision type made. So it's your initial approach, and then if it was robotic VATS or thoracotomy or transcervical robotic or VATS, then you will answer the corresponding questions. And if you answered yes to planned or unplanned, then we want the conversion approach for the transcervical robotic or VATS if it was converted during the procedure. The intentional resection of functioning phrenic nerve is still there. And then the next question we added in to be apparent to the following section. I'm trying to remember why because it's specific to just thymoma procedure. So we wanted this on all of those procedures that were collecting the thymectomies, mediastinal masses, and procedures for myasthenia gravis. And then specifically for thymoma procedures, we wanted this additional detail. We have the pathological staging, no major changes here. And then and I think that's it for that one. And then for all procedures, we ask the completeness of resection, and then was the patient alive at 30 days post-op. And then the additional questions, no major changes there. We did get rid of, go ahead.
We did change the parent for the WHO classification. So we kind of bury that in the thymoma question instead of having you tell us it wasn't a thymoma. So you will see how you've yellowed out the not thymoma.
Oh, I see. So if not, no cancer found. So if you do not select no cancer found, then you'll be asked to answer the WHO classification question.
Right.
Thank you. And then the 90-day post-op operative variable, we kind of rearranged the section a little bit for the 30 days and 90 days, patient alive at 30 days. If they're alive at 30 days, and then we ask if they're alive at 90 days, so you can then fill out that additional information. And I think that's going to be a good place to stop. Is there any questions on this section? Katie or Dr. Wormuth, do you have anything that you'd like to emphasize or discuss?
No, I think we're good.
Okay. And Leanne's dad was found. He's all okay now. Thanks, everybody. Here's some in the esophageal clinical stage section. In the esophageal clinical stage section, how are we going to pull the data if we can select multiple clinical stage methods like PET, CT, and CT and bronch? I think you are making too difficult data structure. So we've done this with adult cardiac. You pull the data out using the harvest codes instead of the short names. And we haven't had too many issues. Sites in Michigan have been having a fine time doing that with adult cardiac, and they use their data for all different things at their institution, especially University of Michigan. And yes, we have thought about data pull. Back to the JTube for JTube placement, discharged, but then within 30 days. So we'll clarify in the training manual on that one. Dr. Wormuth would like that answered out to 30 days. So we will clarify. I just want to make sure we're not double capturing something down in the, I think we moved that up. Dr. Wormuth, if I'm correct, didn't we move that up from a complications type section? I have to go back and check it out further, and we'll clarify in the training manual what we want to do with that one. And I will have an answer on the 38746 code on the next call. So I think we're all done here. Thank you, Katie, and thank you, Dr. Wormuth, so much. Sorry for, and I see Catherine joined. Thank you, Catherine. And I'm not sure if Leanne can hear us or not, but all is well with her family. So thank God for that. Okay, everybody. Thank you. I hope you have a great day, and we will talk again soon.
Thanks, Carol.
Thanks.